Well, basically, the examination setting is very important. You have to screen the patient appropriately, obtain informed consent. If, you know, in the proper examination setting, if there's any fan that is blowing, you have to stop it. The window blinds, okay, ordinarily should be covered. Of course, if patient is wearing any head covering, you have to also remove it. So those are some of the precautions that you take, of course. So you introduce yourself to the patients. Good afternoon, ma. My name is Dr. Tolani. I've been asked to conduct an examination on you. Okay, it's going to involve me touching your neck, some parts of your head, and some other parts of your body. But I promise to be as careful as I can, and I promise that it won't be a painful procedure. You give me the permission to go ahead.
Yes.
Okay, so of course, so she has given me the permission. Of course, if there's anything, you know, on the neck, she will have to take them off. Like I said, any head cover also has to be off. Okay, so we start the thyroid examination in front of the patient. We complete it usually, you know, at the back of the patient. Okay, so most of the time in the examination setting, you will see some of them having a glass of water beside them, but you may not see, so you still need to ask whether they actually have a glass of water or not. So of course, the first thing that you do is to inspect. So you ask the patient to actually, you know, sort of extend their neck a bit and see whether you can pick any neck swelling. I can't pick any obvious swelling on her neck, okay, but I need to be sure, okay, because I've not touched her, it's just on inspection. So what do? I ask her if she has a glass of water, and then she takes the glass of water. So do you have a glass of water around you? Okay, so she doesn't have. So you can, for the purpose of the examination, we'll ask her to swallow. In the proper examination, you have to ask, because some of them is going to be hidden under the chair that you cannot see. It's only when you ask that the patient will tell you, yes, I have a glass of water. So we now go ahead. Can you swallow, ma? Can you swallow your saliva? Have you swallowed? Okay, so so she swallows. Can you bring out your tongue? Okay, so she protrudes her tongue. And this one is actually to help us to distinguish between a true thyroid mass and a thyroglosal cyst. We know that thyroid mass will move on swallowing, but will not move on the tongue protrusion. But the thyroglosal cyst will actually move on the tongue protrusion. No? So after this one, there are two schools of thoughts. There's a school of thought that believes that you can still conduct some other aspect of the examination in front of the patient. There's a school of thought that believes that after you have done this, you should go to the back of the patient. And like I usually tell people, where I was trained, undergraduate, postgraduate, they stick with the second school of thought. I also, you know, advise residents to go with the second school of thought, because that is the more popular school of thought, okay, between the two. So I'm going to go to the back of the patient, and what I want to do again is just to demonstrate what I saw. Okay, let's say that she has a neck mass. Okay, so I put my hand there and I ask her, please, can you swallow, ma? Okay, so she swallows. I will now really see that that thing is moving. Can you bring out your tongue? So she brings that. So I now know that really there is no, it doesn't move on tongue protrusion. So what do I want to check? I want to be sure, is there any differential warmth? Okay, and I usually tell people, when you're checking for differential warmth on the neck, don't check very close by, okay, because if you check very close by, there's an inflammatory reaction, it can still spread, you know, up to the upper part of the chest. So it's always good to go to a distant place, or if she wasn't wearing what coat, maybe on the arm, okay, you check. Okay, so I know that there's no differential warmth, so I want to check whether there's attachment to the overlying skin. So I can see that there's no attachment to the overlying skin. So I want to check whether there's attachment to the underlying structure. So let's say there's a mass here. So what I will do is I will stabilize the mass here and try to displace the mass. Okay, so I can easily displace it. There's no mass, but let's say there's a mass, I will know that I can easily displace. So there's no attachment to the underlying skin too. Of course, I want to know what is the consistency of this mass. So I stabilize here and I use this hand, okay, to feel for the consistency. So it can be soft or cystic, it can be firm, okay. In cases of Graves' disease, okay, then it can be hard in cases of thyroid malignancy. So those are the few instances that you can see. Of course, I now want to measure this mass that I've noticed. Don't use the crude method. Ideally, we should use the tape rule. So, of course, I locate the lateral extent here, put my tape measure, the inch side is facing, you know, the examiner, Then I measure the width, then I look at it, show the examiner, oh, this is 5 cm. Then I come to the upper part, okay, place my tape measure and then measure the height, okay, and then again I show the examiner. Then lastly, before I leave this, of course I want to see whether I can get below this mass or whether there's any form of retrosternal extension. If I can get below it, there's no need for me to percuss, okay, because I can get below it. But if I cannot get below it, then I may need to percuss to know, you know, the lower extent. So of course, and the normal thing is just it's going to be dull. Then when it is no longer dull, you know that that's actually the lower extent of the mass. So once I'm done with that, the next thing is for me to listen whether there is a carotid bruit. Okay, stethoscope. Do you have it? Does anybody have a stethoscope? Of course, we know that bruit generally, you know, is a pointer to high vascularity, okay, which is what we classically see in patients that have Graves, okay, but sometimes it might not be present. So just listen, okay, over it. Of course, there is no mass here, but if there was a mass here, usually I tell people that there are 3 sounds that you must pay attention to here. For every patient, for every person, you hear the 2 sounds. But if you hear the 3rd sound, then you need to pay attention whether it is a bruit or not. Okay, the 1st sound that you hear is usually the carotid position, okay, which is the normal lob dub lob dub. So gudum 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 gudum. That's what you hear. Okay, then you can hear the respiratory or the breath sounds too. Okay, so that one has a crescendo descendo. Okay. Okay, that's what you hear. Okay, the 3rd one, which you can also hear, is the carotid bruit. Okay, in which case a monophasic sound. Okay, so it keeps blowing. So you must be able to distinguish between the 3. There was a patient that we saw in the clinic, I think a few weeks ago. I just wanted to use the patient to teach. Were you there with me? Okay, I just wanted to use the patient to teach the medical students. Because patient had already been treated to remission. I never knew that. Of course, the gutter was still there. I never knew that patient actually still had, you know, bruit. And lo and behold, I listened. I was like, this is, you know, carotid bruit. So we paid. This is a thyroid, you know, bruit. So we paid attention, and the students were able to listen. I think Dr. Adefolaji also. You listened that day too. Okay, and you actually. So once you hear 3 sounds, delineate the carotid position. Also separate the breath sound. That other sound, pay attention, is likely to be, you know, a thyroid bruit. So when you are done with that, the next thing that you do is you want to check for locoregional lymph nodes enlargement. So so you turn the head of patient like this, and what are you looking for? You want to locate the sternocleidomastoid muscle because it is an important landmark. The cervical group of lymph nodes, we have the anterior group and then the posterior group. So the anterior are just anterior to the sternocleidomastoid, and then the posterior also posterior to it. And you have again 3 groups: the superior, the middle, and the inferior. Like I usually say, if you have large fingers, you may be able to pick everything together, but I have small fingers. And to demonstrate to my examiners also that I know what I'm doing, so usually I go, okay, for the superior, for the middle, for the inferior, again back here, okay, then there, okay, then I turn. You don't do the 2 at the same time, so that you won't be compressing on the carotid artery, which can actually, you know, elicit some reaction that you don't want. So again, you check, you stabilize, you check, again, you check, and then you check. So first, I've checked that. So you check other group of lymph node, the submandibular lymph node, like I said, pop your fingers, and then you rub it against the bone, okay, then the submental, okay, you check. Of course, you check for the, you know, anterior, pre-auricular, the post-auricular, then, of course, you know, you can check for the hospital. So after you are done, you now come to the head of the patient. So you look at it. Does the patient have any nodules or swellings on the neck? Because, on the skull, because we know that for those who have thyroid malignancy, one of the first areas of metastasis is actually on the skull. So you check, okay. That's why the patient must have taken off the edge here. For part 1 exam, usually in between exams, they will always have the patient to put on their head cover deliberately. So you have to be conscious of that. Please, can you help me remove? So you check. I can't pick any mass here. Okay, so I can't pick any mass. So the next thing is for us to now go to the eye examination. So really, I'm done with the thyroid examination now. The other ones I want to do is actually to look for other aspects. So can you hear me put off your glasses? Okay, so you bend the head of the patient, the neck of the patient like this, as if you slightly flex it, okay, and then you look down to see whether you can see the eyeball protruding out, which I cannot see in her. So it does appear like this lady does not have exophthalmos. Okay, from here, if she has exophthalmos, you will see the eyeball protruding beyond, you know, this side. So you see it protruding, okay, which I cannot see here. Some people have said that you can actually be more objective, okay, by doing the pen rolling method. Some people disagree with it, that it is demeaning for the patient, but you can do it. Okay, so what you do is you put it like this, and then you roll this pen, okay, freely across the eye of the patient. Now, for patients who have exophthalmos, what you get is when you are rolling the pen, okay, it gets to a point that the pen will not be suspended by this, rather it will be suspended by the eyeball. So this is what you get. Do you understand? So it will not be touching this one. It's not this one that will be touching, that will be suspending it. So again, you do it like that. Okay, so and that is it. So when you are done with that, then you can come to the front of the patient, okay, to complete your eye examination. Of course, you want to check for lid lag, you want to check for lid retraction, you want to check for ophthalmoplegia. So for lid retraction, it's just that you can see the upper sclera below the upper eyelid. So this is how, so you just ask her to focus on one thing. Okay, can you look at this lady there? Okay, so this is what you see if she has a lid retraction, right? So you'll be able to, this is how she'll be looking. So you'll be able to see this upper sclera below the upper eyelid, which is not supposed, you know, to be seen. Then for lid lag, what you want to see, whether the upper eyelid will be lagging behind the eyeball. So you just ask her, please, can you follow my finger as I move it up and down, right? Okay, so you start gently, then you now move very fast, okay, and she keeps moving. So if she has lid lag, okay, this is what we have here. Yeah, so you can see that, okay, which ordinarily, you know, because she doesn't have, and the reason is we have said that in thyrotoxicosis, there can be adrenergic, you know, stimulation. Okay, so because the thyroid hormone actually shares some homology with the beta receptor, so it can actually bind to it. So when it binds to it, when you are moving too rapidly, there's no time for relaxation of the muscles, so it now lags behind the eyeball. So that is what you saw. So then you now do your ophthalmoplegia, which is you want to check the extraocular muscles. So you stabilize the head of the patient. Can you please follow the tip of my finger? So you go down, okay, then you go like this. So you write your age, okay, and you ask her to follow. So you come again, okay, you go, then you now check for convergence too. So please follow my finger. Can you follow it with your eyeball? Can you follow? So we can see that she has, you know, relatively good convergence. So we can see that she doesn't have any eye, you know, eye abnormality here. So then you now come to the hand of the patient. So you want to shake the patient and see. We know that patients who have thyrotoxicosis, they could have, you know, moist and you know, sweaty palm. Okay, so you shake. Okay, our own is dry. Okay, there is nothing, okay, like that. Of course, you check if she has any palmar erythema, okay, which I cannot pick here. Okay, so then you want to check for finger clubbing. Okay, so you check. I can't pick. So it must be at the level of your eyes. I can't pick. But then you know that the first few stages you have to check for fluctuancy. So I can't pick any form of fluctuancy. Okay, here. Okay, then last, before you leave this place, you also ask her, you want to check for tremor. So you look at it, whether there's any form of tremor. You can't pick a tremor. So let's say that this is a sheet of paper, then you put it. That's why you also have, you'll have covered, you know, the window blind and then switch off the fan. So you place it there and see whether you can pick some fine tremor, which I cannot pick it. So she's fine. Okay, so then I will now count her pulse rate. Okay, I will count the rate. I will look at the rhythm too, because one, beyond tachycardia, because tachycardia is the commonest arrhythmia that patient with thyroid auscultation can have, okay, whereas hypothyroidism patient, they can have bradycardia, but they could also have other arrhythmias too, especially atrial fibrillation. So we are counting, okay, the pulse, we are counting the rate, and also checking for the rhythm. So I can't pick, I think the rate here is fine, the rhythm also is fine. So you come to the leg of the patient, okay, sorry, yeah, okay, and then just, you know, we are checking for pretibial myxedema. So you now rub your finger on it, okay, to see whether you pick any elevation. It's not for pitting, okay, because typically it gives a non-pitting edema. So you just rub your fingers on it, and if there is pretibial myxedema, you will see, you know, you will see that elevation, okay, sorry, okay, so I can't pick any abnormality here. Some people believe that, you know, the thyroid examination, that by the time you get to this point, you have done well, okay, but usually we want to do one more thing. Okay, so can you stand up? So you ask the patient to now put their legs, okay, on the chair like this to check for ankle jack. Can you do that? Okay, we don't have a patellar hammer here. You can still do it. Okay, so you just you know, locate this place, and then you hit your patellar hammer, okay, to see, you know, what the reaction here will be. We know that patients who have thyroid auscultation, they could actually have you know, hyper reflex. Okay, come take it down, then you do for the other one. So by the time you have done that, then you will have finished your thyroid examination.